welcome back to the channel, The Beast on. I am The Beast, Brian London, and I appreciate you coming to the channel. If you can, do me a favor, hit the subscribe button if you can. Also hit the little thumbs up button. It's right down there. Hit the little thumbs up. Tell Google you like the video. It'll tell everyone else you like the video, and we'll be good. And then hit the little bell. It's right, should be down there somewhere. Yeah, it notifies you when new videos are out. So subscribe to the channel, like it, hit the bell, and follow me on all the socials at Miami Radio Beast. Today's video is a really good one I've been working on for a while. A couple days ago, if you're watching this, it is Wednesday, May 5th. Happy Cinco de Mayo, by the way. Feliz Cinco de Mayo! I probably said that horribly, but I tried. So a couple days ago, I did a great interview with two wonderful female doctors. They are friends, and one of them is actually one of my doctors. They are Dr. Amy Pearlman and Dr. Michelle Pearlman. Dr. Amy Pearlman is a urologist practicing out at the University of Iowa, and Dr. Michelle Pearlman is a gastroenterologist and a weight loss doctor. Wondering why I'm seeing her at the University of Miami. They are amazingly smart, amazingly funny, and they've got great information for you about all sorts of stuff. A lot of men's health stuff. Amy likes to deal with the man parts, if you will, professionally. I'm not going to touch yet. Never mind. And Michelle is here to help you and everybody in her life eat right and lose weight and be healthy. And she performs a couple colonoscopies every day on the side just to, make sure the electric stays on. They're amazing. They're awesome. They have made such an impact on my life, and I want you to hear from them. So without further ado, I'm telling you, you're going to enjoy this video. You are. Stay through it all. You're going to learn so much. It's going to be amazing. Without further ado, let's bring in Dr. Michelle Pearlman, MD, gastroenterologist, weight loss doctor, Dr. Amy Pearlman, MD, urologist. Here we go. All right, everybody, let's bring them in. They are sisters. They're amazing doctors. They're the sisters and doctors Pearlman. Amy Pearlman, MD, a urologist out in Iowa. I need to figure out why on this one. And Dr. Michelle Pearlman, gastroenterologist, weight loss doctor at the University of Miami. Both of you, thanks for coming on the channel. And I love talking to you guys, so that's why you're here. What's going on in your world today? Who wants to go first? It's good.
Amy, you were the second twin out, so maybe you go first.
Oh, okay. Let's see. What's going on today is I did a little research this morning, brought a gentleman in, and used a high-tech ultrasound machine to look at his man parts. Let's see. After that, I did some patient charting because, we see a lot of patients in the office, and part of our job is to write patient stories in their charts so that when other people look at their notes, they know what's going on with our patients. And then I came home and hanging out with this little rascal here. Her name is Lexi. She goes by Lexi, and she's got her jean jacket on. So I'm ready to rock and roll.
I wish the audience could have seen the two of these sisters talking about fashion and what they were wearing and earrings before the video shoot because it was glorious, but I wasn't recording then. If I had been, it would have been.
Brian, we can take 5 minutes now and talk about it.
I mean, we could, but it's not my preference. Michelle, Dr. Pearlman in Miami, what was your day like today?
I did a lot of colonizations, or shall we say colon cleanses or colonics. I kind of hung out at the spa today doing colonoscopies. That's what we do. So colonoscopies, endoscopies. I'm able to tell people they're full of shit and not get fired because, many times it's actually true anatomically. So
Yeah,
that was my day.
Actually, theoretically, and because I've had several colonoscopies, I know that they're not supposed to be full of shit when they see you, right? They're supposed to be all cleaned out.
Theoretically, they are.
Theoretically,
Sometimes, doesn't go as planned.
Yeah, so when I was 17, I had an endoscopy and a colonoscopy, and I opted not to have any anesthesia, because anesthesia is my biggest fear in the world. Any kind of it, like being put out, any kind of that. So I wanted to tough it out, and my doctor was like, "Okay, I mean, it's your choice. Like, feel free." So I got through the endoscopy fine. Blew every blood vessel in my face, but still got through it fine. Went for the colonoscopy and heard the doctor yell at a nurse, "Who cleaned this guy out?" And knew that maybe I, had not. Back in those days, you had to do you had to drink the stuff and do like an enema situation, and I probably didn't do the enema right. I was 17. I wasn't going to let mom help. So I was not cleaned out. So yes, I was full of shit at the time. So that happens, I guess. And you're looking at.
I think what's confusing is a lot of people we promote eat tons of fiber because that it goes fast through the intestines and it helps people with constipation. But in reality, those fibrous like grains or nuts or seeds, that stuff actually stays in your colon. So really what we tell people is 5 days before the colonoscopy, actually cut out the fiber because it clogs our scope and actually interferes.
All right.
I had a colonoscopy on Monday and I asked for no anesthesia. I said, I want to be completely awake. And I actually thought the colonoscopy was fine, but I saw seeds in my colon. I didn't know what they were. I was like, are those parasites? Like things all in my colon. It turns out the salad that I eat, it has a lot of these like black, chia seeds in them. But I had my colonoscopy on Monday, felt a little bit of bloating, but was otherwise fine. I thought I was going to die from the prep. I'll be honest with you. Sunday night, I woke up in the middle of the night. My blood pressure tends to run low at baseline, and it was very low. My little puppy, I was like, Lexi, girl, you got this. I'm going to be dead in a few hours. I'm going to need you to call for help. You'll be okay, babe. But I made it. Here.
I think what the audience can figure out is they don't need me to do this interview. They'll just do it themselves. And that's why I love them so much. They're amazing doctors and people and personalities. But what I want to get into is both of you are into men's health. And Michelle, you do it from a weight loss situation, as well as gastroenterology. And Amy, you do it from a urological standpoint. And why is men's health such an important thing these days? Why am I seeing ads all over my television about men's health? What do you get from men as far as feedback about why sometimes they're a little hesitant to talk about the colonic region or the urologic region? Michelle, feel free to go first since you made your sister go first the last time.
I would actually on this one.
Yeah, Amy, you go first.
Yeah, I'll go first.
Yes.
Okay.
I will first of all say that it's interesting that I went into men's health. I think growing up, I just wanted to understand men better, and for some reason decided to dedicate my career to doing that. One of the things that I really enjoy about my work is I can sit down with a guy regardless of his age. He might be late adolescence or 85 years old, and teach him the basics of his body. And I think that's a wonderful thing, but it also makes me feel a little bit sad that it took Mr. Smith 80 years to find out about how his bladder works and what his prostate does and the basics of sexual function. And, my hope now is that conversation happens earlier. Men are coming in now, and people are advertising and doing a lot of direct-to-consumer marketing now because I think men always cared about their health. We just never we never gave them the stage to talk about it. And so we as urologists and endocrinologists and other healthcare providers, when our guides would come in and maybe say, I'm worried about low testosterone. I feel tired. Is it a midlife crisis? I want to feel better. If they don't have a diagnosis of high blood pressure or diabetes, they just never really fit within our healthcare system. So what happened is as testosterone therapy became more and more popular, as these clinics that are really owned by business people, they said, well, nobody else is taking care of men. We're going to take care of men. And they build these very convenient places, and they're very nice. I've been in them before, and you walk into the clinics and it has these beautiful motivational words on the wall, and it's clean, and you walk right in and you don't have to wait an hour. If you come to see me in clinic, you're probably going to wait 1 to 2 hours to see me. And what hard-working man wants to do that? Not many. So these clinics have really capitalized on saying, hey guys, we want to help you feel better, and we'll treat your low testosterone. And they encourage men to seek help. And I think, a lot of what I see in the office is guys who come in and they ask really good questions about their body. Why does my ejaculate volume go down? Why does it hurt when I ejaculate? What's wrong with my penis? Why is it curved to the left? Why does my ejaculate look green? And they're asking the questions that we ask them to ask. We say, pay attention to your bodies, go see your doctor if you notice any changes. So they do see their doctor, but a lot of doctors don't know how to answer their question. So they say, Billy, you're normal, you're fine, or I'm not sure what's going on, drink more water, whatever. And so I see a lot of these guys that they're like, I've seen like 5 different people, nobody knows what's going on. I want a diagnosis. I want to know what's going on. I know my body better than anyone else, and something is different. And I'm sick of people telling me I'm normal because something is different. And so I think in general, as healthcare providers, we're way behind, I think, women's health in terms of understanding how to counsel men on their bodies. Because men want to know. You can see on Google and all these searches, men are asking the questions. They're not asking their healthcare providers, but they're asking Dr. Google because they want to know.
Michelle, you see the other end of the body. Colon cancer is obviously a big, it's a big killer in this country, both men and women, actually. But, men sometimes are reluctant, to go see someone about it. I'm the opposite, I get a sniffle, I want to see 7 specialists. But most men aren't like me. But, it's important. It's important. Colorectal health is really important for men. And the other part of your job in weight loss it's really important as well. I think there's been a stigma with guys trying to lose weight for a long time. I think a lot of the weight loss companies advertise more to women than they do to men. I don't know if that's been proven or not. It just seems like my point of view. So from your standpoint, your thoughts on men and taking care of themselves.
I don't know. I guess it's hard for me to comment on that because the men I see in clinic obviously made the hardest step and they come to see me in clinic. So there's obviously a much larger percentage of the population that are not ready to take that first step to seek help. But if they show up in my clinic, they've already made that step. And what I tell a lot of people is they did the hardest part, and that was showing up. Actually, I'd say, and the second hardest part, particularly in Miami, is showing up on time. Because if you're on Miami time, and you show up 30 minutes late, you're actually running early. So when you show up when you show up, number one, and if you show up semi on time, then it speaks volumes, right? That means that you're ready to make a change. Particularly if people are seeing me for weight loss. I'm not a primary care doctor, so it's not like a patient's coming to see me for their annual and I have to sell them the fact that they need to lose some weight. They must have told someone that they were interested in losing weight, and that's how they end up in my clinic. And so I see kind of just a subset of the population who clearly is kind of more motivated and have already recognized that they have a problem. I would say, though, that, honestly, I can't give you the exact numbers, but the majority of my male patients have no problem talking about their bodies. And I think a lot of it just has to do with the whole doctor-patient relationship. If I walk in like super awkward, and start asking right away, like, are you pooping yourself? And it's all in the way that you ask these questions. These are very embarrassing questions, whether it's genitourinary problems or gastrointestinal problems. And I think if, because in what other field or kind of business do you walk into a room And within 30 seconds, you meet each other, and then you start talking about how often are you having diarrhea, and are you having any blood in your stool, any rectal trauma? I mean, those are very serious questions. So you have only a small amount of time to develop that relationship, make them feel comfortable to kind of share these very vulnerable parts of their life. But I would say my male patients seem to open up just as well, and sometimes actually even more than my female patients.
Yeah, and I'll second that. I just want to jump in real quick. Sorry to interrupt. You know, the guys who come to see me, none of them come in saying, Dr. Pearlman, I want to lose weight, but I actually do talk about weight quite often in my office. If they're coming in with hormone concerns like low testosterone or decreased, sexual function, or any type of genital pain, towards, maybe in the middle or towards the end of the visit, I'll simply ask, sir, where are you in your weight? Are you up, down, or about the same that you've been? And so often guys say, oh my God, I'm up in my weight, I'm trying to lose weight and I'm struggling. And then we get a little bit into the nutrition and exercise component. And that's where I actually direct a lot of these patients to check out my sister online to look at some just basic information on nutrition. But it's just, there's so many doors that guys walk into the healthcare system that it's really, as long as we as healthcare providers create a safe environment, it really should be every single healthcare provider who brings up these basic issues about nutrition and exercise and weight with our patients, because it really affects every single disease, process, and symptom that drives patients into the healthcare system.
Yeah, no doubt about it. All right, I want to go from here, but back kind of to your beginnings. You two obviously are twins and grew up together. So how did you both decide to get into medicine and to get into your specialties and to end up where you are? With Michelle, you're here where I am down in South Florida, and Amy, you're out in the land of Iowa. Where I did lose a bunch of money at a casino, but that's a story for a different time.
So Amo and I grew up in Rockville, Maryland, and the only thing we wanted to do outside of high school was to leave Rockville, Maryland, and explore the world. And so we figured, hell, why not Miami? It seems like it's nice weather and a fun place. So we did 4 years of undergraduate here, and it was interesting because after 4 years of being in Miami, I was like, well, maybe I need a smaller town. I think Miami's a little bit too hustle bustle, crazy, too much drinking, things like that. So then I made the decision to go to Wake Forest in North Carolina. 4 years there, I realized, well, maybe I need more of a city. So then I went out to San Diego, and then the one day out of the year that it started raining, it was like a shit storm because no one could handle the rain because it's always such perfect weather. But nothing better than going to Coronado Beach after a 28-hour call. So that I was there for residency. And then I went to Dallas because I heard, bigger's better and everything's, I guess bigger in Texas. I don't know. You can edit that part out. No. So I went to Dallas.
Especially the colons are bigger in Texas.
Yes.
So I went to Dallas for fellowship training. And what was interesting and what I encourage people to do is throughout your training, if you have the opportunity, go to various places because everyone has very different sort of practicing styles, and particularly the patient populations are so culturally different. One of the reasons why I wanted to come back to Miami is because I wanted to build a weight loss practice. And what I learned from all those different regions was that I needed to be in a place that seemed a little bit more health conscious. And I didn't really have that in Dallas. I just remember patients coming in. I remember one guy, very nice guy, he'd come in with a huge super gulp, whatever you call them, from 7-Eleven. And every time he'd walk into my clinic, he would say, I'm so bloated, I don't feel well, can you fix me? And every time he came in, I said, do not bring that soda into my clinic room. We talked about this last time. And I just remember him looking back at me and saying, there's no soda in it left. He had already drinking all the soda. It was just ice left. And so that, I felt bad for him because there was so much that I could have done to help him from that nutritional standpoint. But a lot of it just has to do with cultural norms and whether or not people are actually ready or not to make a change. Here in Miami, again, I'm very fortunate because people are referred to me because they've already expressed that interest that they need or want help. So the patients that I work with are truly motivated and vested in making those changes. And so that sort of environment, I think, makes my job easier and more fulfilling.
Amy, how'd you get to Iowa?
Yeah, and then, my sister and I actually crossed paths, but not at the same time during our training. So like my sister, I did my 4 years of undergraduate at the University of Miami, and then did medical school at Baylor College of Medicine in Houston, Texas. So not too far from Dallas. In the Texas Medical Center, which is just a huge medical center in Houston. It was just a wonderful place to train. I did 5 years of urology residency training at the University of Pennsylvania in good old Philadelphia. And then I did a fellowship year, specialty training, so men's health, reconstructive urology, and infertility in North Carolina. So actually where my sister did her medical school, I went to fellowship. And, and then I just really wasn't sure if I wanted to do academics or private practice afterwards. And you spend so much time, money, and resources during your training. And when it comes to the end and they're like, well, what do you want to do now? You're like, I don't know. No one's ever asked me that before. And so I ended up taking this job at Iowa in academics. And that's how I ended up here. But if you were to tell me 10 years ago that I'd be living in Iowa in my mid-30s, I would have said there's no fucking way. But that's because I grew up on the East Coast and trained at a lot of different places. And Iowa, as people say, is a flyover state. The whole Midwest is a flyover area. But I think it's a very underappreciated area. People in the Midwest are very nice and collaborative, and I've actually been very pleasantly surprised with Iowa.
Yeah, I actually spent a lot of time, well, not a lot of time, but a good amount of time over the years covering the College World Series in Omaha, and would always drive into Iowa for road trips or day trips or whatever, and love the people there. So we tend to maybe not think about those states, but they're great people, and they need your help just as much as anyone on the coast or anywhere else, right? So great choice. All right, so we got to know you a little bit. And I don't want to get to the funny stuff yet. There's going to be some funny stuff. We have to do some entertaining. It is my channel, and that's what I do. But the medical stuff is really important. So we'll start with you, Michelle. Weight loss. It's something that a lot of us have battled, and I'm not sure. We'll be transparent, right, and tell the audience that I see you as a patient, but we're not going to talk about me. This isn't about me, although I will discuss something else that neither of you have seen me for coming up. But in trying to battle my own weight problems throughout the years, I've always, been put on this fad diet or that fad diet. There's keto, there's intermittent fasting, there's go to this place, go to that place. But none of it has really worked for me. None of it has managed to catch on with me. And I know everyone's always said, oh, well, it's a lifestyle change, but not a diet. But it ends up turning into a diet, not a lifestyle change. And that's where I personally run into issues. So how do you combat that in your practice? How do you combat this person is doing the keto, the intermittent fasting, this diet, that diet, whatever, and try to get through to them that no, it doesn't work like that?
Yeah, the people that show up in my clinic, it ain't their first rodeo.
Correct.
They've been struggling with weight for honestly most of their lives. Some of the heartbreaking stories that I hear is particularly people who lived overseas, or just anywhere outside the United States. And one of my initial questions is, when did you start gaining the weight? And what's really sad to me is really anyone who grew up outside the United States, they almost 100% end up saying, when I moved to the United States is when I started gaining a ton of weight. And I just think that's awful, because we have so many resources here. And despite all the medical advances and the quote unquote health food industry being $1 billion industry, clearly what we're doing is not working. Because if you look at the prevalence of obesity, it's the same now that it was over 20 years ago. And if you look at actually the pockets of those with a BMI over 40, so morbid obesity, those are actually going up, particularly in women. So despite all the medical advances, all the fancy procedures and bariatric surgery and medications on the market, something is clearly not working. If you look at all the guidelines, whether we're talking about heartburn, whether we're talking about certain cancers, whether we're talking about urologic symptoms, the first line therapy is always lifestyle modification. So it's easy in a physician note to say at the end of our note, counsel patient on lifestyle modifications, right? And we type what we call like a dot phrase where it's already pre-populated. We put it in the patient's after visit summary. It's a very generic page of you need to move more and eat less and cut the carbs, and I'll see you back in a year for your annual. So we kind of check off the box and say, yeah, we spoke about lifestyle modification, but that is not good enough, okay? Because lifestyle modification is the crux of everything. And it's so incredibly important to figure out, why has someone struggled? When did it start? How fast do they put on the weight? Who else is part of that family unit? Because we do not live in a bubble. And so I can control or, try to persuade one person to change their eating habits. But if they have a bunch of kids at home and partners and things like that have different dietary preferences, that plays a huge role. What their budget is, their time constraints, what they like to eat, what they don't like to eat, their food allergies. I mean, I would need, honestly, a week or so to figure out all this information for each patient. But unfortunately, in the healthcare system, by the time the patient shows up, is checked in, gets in a room, I have 20 or 30 minutes to figure out all that information, plus teach someone the basics of nutrition and then give them a plan. So I think setting up expectations from the beginning is important, because patients, they may have waited 3 months to see me. And when they come to see me in clinic, many of them expect for once they leave the appointment, something's just going to click in their brain and just say, well, now it's easy because I saw Dr. Pearlman. And it ain't that easy. My goal is to educate people and give people the tools and then make it an ongoing partnership for what's going to work for them. So people come in on cookie cutter diets. They never leave being on a cookie cutter diet, because I try to, I guess, quote unquote, make it cookie cutter for them in learning what they like to eat and then making just small changes with that.
Amy, Michelle talks a lot about understanding her patient and her patient's needs, and more than just they're a number and, we need to check these boxes through the appointment and what have you. In your field, how important is that as well, is understanding that particular patient, their needs, their fears sometimes when they come to see you about what may be wrong with them. Certainly it could be a taboo subject, but understanding that patient as an individual, how important is that?
It's my entire practice. I specialize in quality of life concerns that affect men. So for the most part, nothing that I treat will kill anybody. Some people might think that their erectile dysfunction will kill them. Maybe their underlying heart disease or untreated sleep apnea, will be their most important factor to treat. But nothing that I do will kill anybody. So nobody has to see me. And so like my sister, the people who actually show up to their visit and come in, they've usually been waiting a little bit of time. And so they want help. They've chosen to see me in the office, which means they're asking for help. And it's really hard for some of these guys to come in and say, my penis doesn't work, or I orgasm too quickly after a minute and I'm 19 years old and it's really embarrassing, or a girl used to sit on my lap 2 years ago and I used to get a hard on and now that doesn't happen anymore. What's wrong with me? And so one, I will say it is a big milestone when any of those guys show up in my office, and I make sure to tell those guys the same thing that my sister does is, wow, congratulations on making it to your visit today. And I don't say that as a demeaning comment. I'm like, congratulations, this is amazing, because most people never make it in to see someone like me, and that takes a lot of courage. But everything is about understanding the patient. And like my sister's practice, when I deal with sexual health, everything is about understanding their relationship with their partner. And the trick in my practice, like my sister's, is the time constraints. How do I understand all of the goals of the quality, male-specific quality of life concerns affecting this guy, but also how that affects his partner, what his partner is interested, in having as well. When we talk about something like fixing erectile dysfunction, that's one of the easiest parts about my job because I have a lot of tools in my toolbox. But you talk about a penile implant. You put a penile implant in someone who's 70 years old, whose, let's say, wife is going through menopause, and you tell that couple, hey, Bob, I'm going to put this implant in. You're going to be able to get an erection whenever you want, maintain it for however long you want. How awesome does that sound, Bill? And Bill's like, well, that sounds awesome. And Sally is like, holy shit, what is Dr. Pearlman about to do for my life? Because right now, like, Sally might be interested in having sex, but not for 5 hours, because Sally's going through menopause, and it might be really painful for Sally to have intercourse for that long. But also, most people probably don't want to have intercourse for 5 hours. I think a lot of men think that we as women, or whoever their partners are, regardless of gender, want to have intercourse for that period of time. But the reality is it's so rare that two people actually sit down and say, what does good sex look like for you? What does intimacy look like for you? Where does it feel good when I touch you here? Where do you not want me to touch you? What are the rules for tonight? What are we allowed to do? And we never have those conversations. So we assume that penovaginal intercourse is going to do the trick, and those are big assumptions for really important topics. So it's all about the partnership.
I'm just going to interject for 1 second. Did you happen to be one of those kids that love to play the penis game? Like your family's out at a restaurant and, you're just getting served in the diner and you would just like to yell penis just because?
No, neither my sister nor I were ever the penis kid, but we love talking about sex. I remember just as a kid that I just loved talking about sexual health, and I don't really know why. I just thought it was fun. I enjoyed talking about that stuff when I was in high school and college, and realized when I'm deciding on the type of career that I want to do, it's how do you tell your parents you want to be a urologist? Well, it's amazing. My parents encouraged me to become a urologist, and I'm still trying to figure that out. I was deciding between emergency medicine, pediatrics, and urology, and my parents were like, we really think that you should do urology. But what I get to talk about on a daily basis is relevant to so many people. I talk about men's health and sexual health. And so for with my sister, nutrition, that affects everyone. So many people like to hear about this stuff that it makes it really fun. I'm not, of course, studying and talking about rare conditions is so important. And I'm so grateful that other people specialize in that. But I'm also grateful for the work that I get to do because a lot of people are interested in hearing about it, which makes it fun.
Michelle, with both of you, actually, with both what you deal with, a lot of it has to do with up here, right? Up in the head, psychological, emotional, that sort of thing. That depression, anxiety, all of that stuff can feed into whether it's weight gain for you, Michelle, and your patients, or sexual issues for you, Amy. But, having to deal with that, I think that's also an underserved issue. But understanding that has got to be really important as a doctor, right, Michelle?
Yeah, and I think it's all in the way that you phrase it. When if patients say I've been really anxious, I'm having terrible heartburn and bloating, and I can't stop eating, I'm always hungry, then if I just come back and say, well, your endoscopy was normal, your colon was normal, your labs were normal, it's all in your head, that doctor-patient relationship is now over, because they are going to take that as my doctor is saying I'm crazy and I feel something and I don't feel normal, and now she's not going to listen to me. So I think the way that you phrase it is so incredibly important, in that when people say it's all in your head, that doesn't mean that we're saying people are crazy. That means it's a true biochemical response, where when we are stressed, when we're anxious, when we're bored, when we're happy, when we're sad, that affects our neurotransmitters, our dopamine release. It causes, particularly, let's say when people eat sugar, that stimulates reward centers in our brain, the nucleus accumbens, release of dopamine, and it makes us crave more sugar. These are true physiologic events that occur that then influence downstream choices. So although I may not have a test that says someone's a sugar addict, I know the way that sugar affects the brain. And so if I tell someone, I understand you're anxious or you're bored, and I understand that your coping mechanism is going for, things with high fructose corn syrup. Let's figure out, and that's causing your weight gain. Well, yeah, I can tell you don't have any cookies, and that's easy for me to say. But at the end of the day, that person is searching for something to satiate or calm down some sort of craving that is being driven by some sort of emotional feeling. So I have to figure out, okay, what is that emotional feeling and when does it typically occur? So what I ask my patients is like, when is your witching hour? When do you tend to raid the pantry or go into the fridge and search for whatever is there because you just need to calm down and just decompress? And for a lot of people, it's when they get home from work. And I'm the same way too. So what I tell people is you have to give them a tool. You can't just say, close down the kitchen and go to bed and just go to sleep. That ain't going to happen. If I could give my patients a prescription pad that said stress be gone, I'll see you in 6 months, I wouldn't have a job. And so the goal is to figure out, okay, the stress is going to be there. And when one stress goes away, 3 more things are going to pop up. So stress is always going to be there. So when we feel stressed, what can we do about it? And I actually told one of my rock star patients, whenever he got home, he'd go in the kitchen, drink some wine, and kind of graze while his partner was cooking dinner. So I told him, I said, I want you to do some sort of planned activity, whether it's yoga, walking, meditation, going into the pool right when you get home for 30 minutes, because you're obviously not burning that many calories doing that, but you're actually quote unquote burning calories because you're not eating or drinking 400 calories while you're in the kitchen. So that's actually, now you're in a negative balance of 400 calories. So it was funny because I also see this guy's wife, and his wife came to see me in clinic, and she said, I have to clarify something with you. I got home and my husband was literally just standing in the pool. And I told my husband, no, Dr. Pearlman said, you need to swim, you need to move more. And my patient said, no, Dr. Pearlman said, I only need to get out of the kitchen and do something with my body. And it doesn't mean that I have to actually move in the pool. So he just stood in the pool. But you know what? It worked for him because it actually saved him 400 calories that he was otherwise going to eat.
I want both of you just to talk to the audience about what they need to look for, or what signs are important to look at as far as, Michelle, with you needing to do something about your weight, and Amy with you as far as you would put it, your man parts. What are, I'm a coming up on 45-year-old male. We'll start with you, Amy. I'm a 45-year-old male. What should I, what kind of like personal things should I be looking for, or signs, that I see? Should I, look for a urologist or see someone like you? What's important to be looking for within my own body?
So a lot of what I do is actually treated by a primary care provider, whoever that may be. And so most genitourinary concerns are treated by a family practice or internal medicine doctor. And at some point that person may be referred to see a urologist. But that person can be referred to see a urologist really at any point in time, because a lot of us specialize in disease processes, so not just medical management. But I like to call, the S's of men's health: sex, streams, steroids, sperm, sleep, size, screening. So maybe 7 S's there. So if you find that your sexual health, whether it's maintaining erections or orgasmic function, any pain with ejaculation, if you find that that's going down and you're not satisfied and or a partner is not satisfied, then it's a good idea to seek help. Now, what you may have heard when you were younger is this phrase, if you don't use it, you lose it. And I used to hear that phrase and I was like, what does that even mean? That doesn't make sense. No, I don't buy it. No true words could have ever been spoken. All right. So if guys are no longer waking up with erections, either at nighttime or in the morning, that is a sign that you're no longer exercising your penis. And over time, the longer that you go without getting regular erections, the penis will shrink. It doesn't stretch like it used to. So my advice for anyone who's no longer getting regular erections is to seek help for that. The penis is an overall barometer of health. So you don't know when your kidneys aren't working. You don't know when your liver's not working unless it's end-stage disease. But a lot of men know when their penis doesn't work. It's a very obvious change that they see. Erection, no erection. And it's all about the blood vessels and the nerves. So the blood vessel to the penis that gives erections about the size of the tip of this gel pen. And the back part of the pen is about the size of a coronary artery. So you can see why I would see a guy who's maybe 45 years old in my office 5 to 10 years before he presents with symptomatic heart disease, because this vessel is so much smaller. So that I would say is a big thing for erections. That's an obvious thing that a man notices a change. But also I see so many guys that are pissed off and frustrated because their penis has gotten smaller. And so I really encourage regular erections. In terms of streams, urinary streams. So if you're straining to urinate, feeling like you're not emptying your bladder, issues with urinary tract infections, frequency, urgency, nighttime urination, other reasons why we might see you in the office. If it's bothersome, then we certainly want to see you. And first line therapy is behavioral modification. I saw a guy yesterday who was coming in with some urinary leakage. We come to find out he drinks a pot of coffee in the morning and Pepsi right before bed. So no 75-year-old can drink that type of fluid in that quantity and get away without leaking urine. And he's 75 years old and nobody had ever had that conversation with him before, you know? And so a lot of it is understanding what we're eating and drinking.
And Amy I would say that I think if that guy were to walk into most offices, they would say it's your prostate, take some Flomax.
Well, he was referred to me by another surgeon for a prostate surgery. You know, and he does have a big prostate. I know that based on an ultrasound. So when I spoke to him in the room, I said, look, you have a big prostate. I might need to take care of that at some point, but let's talk about the basics here about what you're drinking. And I said, do you want me to scope you today to just get an idea of what your prostate and bladder looks like? And he said, no, I'm going to cut down on my coffee. I'm going to cut down on my Pepsi, and I'll see you in 3 months. And then we'll decide if you're going to scope me at that point. And that's the answer I was looking for, to be honest with you. You know, that's a beautiful answer. So let's see, sex, streams, steroids, like you mentioned, low testosterone. You know, low testosterone is also kind of a barometer of overall health, and the symptoms of low testosterone are very similar to other, you know, symptoms of other diseases. Fatigue, waking, you know, getting home and having to take an afternoon nap or feeling like you want to take an afternoon nap. Low motivation, you know, it's like the middle-aged male who meets his midlife crisis and he buys a motorcycle. And I think I'm coming to find, at least in my office, I'm like, maybe that guy has low testosterone. We think he's lazy, but no, maybe he actually has low testosterone. And when he comes home from work, he wants to help take care of the kids and he wants to help cook dinner and he wants to get in the pool, maybe to swim some laps, but he's just so exhausted that he can't do it. So he sits down and he watches TV. I see that guy. And he makes it into my office because he's like, he searches his symptoms on Google and it says, you might have low testosterone. And so he's like hoping that that's the reason why he doesn't have motivation or he's lost his pep in his step. And I see a lot of those guys where they have low T, you put them on therapy, and all of a sudden they're like helping around the house and they're more productive and they have that pep in their step again. So a lot of, you know, low T symptoms that I see in the office. So sex, streams, steroids. I see men coming in with fertility issues, which can also be tied to fertility, size changes, so the penis getting smaller. You know, when people get overweight, that can also bury the penis, sometimes where you can't see the penis either. Screening, prostate cancer screening, that's a really common topic. Prostate cancer is one of the most common cancers that is diagnosed. And the guidelines, it's always about shared decision making. I would say the main thing with screening is if you have a family history of prostate cancer, understanding at what age were those family members diagnosed. We're talking fathers, brothers, and uncles. So if those people were diagnosed when they were young, 50s and 60s, then you're going to want to get screened earlier. If you're African American, you're going to want to get screened earlier. Most men die with prostate cancer and not of prostate cancer, meaning most men on their autopsies, if you look at their prostate, will have prostate cancer, but it wasn't the prostate cancer that killed them. So it's always this sort of shared decision making, because in general, prostate cancer is a very slow growing disease. For the most part, there are exceptions. Yeah, I mean, those are the main ones. I would say in general, if you notice changes in your body and you're worried and you're not getting the answers that you need from whatever healthcare provider you're seeing, then ask to see a specialist. But a specialist in that disease process. Not all urologists will treat these conditions or know how to talk about these conditions. So you want to make sure the biggest thing is to be an advocate for yourself, or to find someone who can help you advocate for yourself and your concerns.
I'll get to you in a second, because I do want to get to the same question, but I just need to interject that your sister Amy has made me regret life, really, because I'm short, Jewish, obese, and like I don't need, I have the use it or lose it situation. So pretty much I have an innie at this point. That's what I'm going with. And it's something I live with and deal with, but thank you for making me think about it in those terms. Whereas, where did Michelle go?
I don't know. She left us.
I'm here.
Oh, she's back. You left us right in the middle of that, Michelle.
No, I heard it.
Yeah, of course you did. But Amy, thank you for scaring the bejesus out of me. I appreciate that.
No, there's nothing.
I will never see a urologist now. I'm going to be shamed.
No, why?
Penis.
No. This is a common thing that I see. I'm surprised that more men don't see me for it because the obesity rates are so high. But I think it's because a lot of people don't know where to go, or they're embarrassed, or they don't know what's normal or abnormal. And there are things that we can do to help. But I would say, the most important thing is seeing what you can do in terms of weight loss, because at the end of the day, it's the penis stays connected to the pubic bone. That's a fixed spot. That is a fixed positioning. And so when there's excess fat on top of that, it literally buries the penis. And if there's issues with yeast infections, you get this chronic inflammatory response, and that tissue can actually, cover the penis. And it's not that there's too much skin on the penis or too much foreskin for someone who may not be circumcised. It's that there's not enough healthy skin that actually keeps the penis out. Now, I do want to clarify something for that use it or lose it point. It doesn't mean, I don't want people to think that they should get an erection and that gives them permission to use it whenever with whomever they want. That is not what I'm saying at all. I'm saying I encourage regular erections for the exercise of the tissue, but not necessarily to use it for anything. A person can use it for masturbation or just to get an erection. He doesn't have to have sex every single time, but it's just like with a bicep or a tricep. If you lift your biceps for 6 months consistently and then don't lift weights for a year, that muscle atrophies and shrinks. And it's really the same thing for the penis. So just regular exercise of the penis overall, even taking sex out of it, is just good for the penis.
We need a penis treadmill. Well, Michelle.
Amy, isn't that what you use vacuum pumps for?
Yeah, so I recommend, Cialis is a really great medication for guys. Taking a low dose daily Cialis to increase blood flow to the penis. But for guys, if they take those pills and they're not getting regular erections, highly recommend a vacuum erection device. There are a lot of ones at adult stores. There are a lot of ones online on Amazon, Adam and Eve, etc. It's a vacuum pump you put over the penis, you put it on and you stretch it out. Sometimes guys will use that before sexual activity, but I really encourage that for actually penile rehabilitation. There's a woman who has an Instagram page called Sexplained. Her name is Rainey, and she has a really good Instagram page where she talks about sex tools rather than sex toys. And I think we have to bring some of those sex toys into the healthcare system to normalize it, to say it is normal, it is okay to use these as adjunct for sexual health. But I would say vacuum erection devices are great sex and penile rehab tools.
All right, so Michelle, it might be a little more obvious of when a patient should come see you for weight loss, but just in case a guy is wondering, am I overweight? Do I need help with this? What are some of the things to look for?
I think the first challenge, though, I think within the healthcare system is a lot of times, depending on your insurance, I would argue that every single person, if you want to really not just survive, but thrive in life, you should really know kind of what sort of nutrition plan is going to work for you. And I think what a lot of people forget is that nutrition is very dynamic. Just like our bodies change with age and there's kind of this normal aging process, what we were able to eat when we were 20 is vastly different from what we can eat when we're 40, 60, and 80 because our hormones change and we're on medication and we're more sedentary and we may have different stress levels and we've had 3 kids and a bunch of surgeries or chemotherapy. These things affect our microbiome in every aspect of our life. And so that's the biggest kind of pill for people to swallow, is that what they can get away with when they are older or when something has happened to their body is not what they were able to eat when they were younger and be 100 pounds less. And so it's a very dynamic process. And so if someone said that they saw a dietitian 20 years ago and they were given just a so-and-so plan and it's not working for them anymore, it may have been that that plan 20 years ago worked for them, but their body is different 20 years later. And I think having access to someone with credible information, using evidence-based medicine, that can help guide them along that timeline to help them figure out, okay, do they have osteoporosis? Maybe we need to increase, foods that are rich in vitamin D and calcium because they didn't really have that issue 20 years ago. Do they have liver disease where they need to kind of maximize some of the protein? Do they now have gout where we need to actually lower their intake of uric acid rich foods? So it's a very dynamic process. I think at the end of the day, it's very simple. If people just ate more whole food that had more dietary fiber, lean protein, and just, moved a little bit more, I think we'd be in a much better place. But there's a lot of nuances to that. If you tell someone who has, let's say, Crohn's or ulcerative colitis, and they're having a flare, and you say, just eat more quinoa and broccoli and cauliflower, they're going to say, hell no, that's going to make me feel awful because it's too much fiber. So there's a lot of nuances depending on the person. So people, who want to see me, I say for insurance purposes, unfortunately, many times for that to be covered, you have to have, either overweight or obese from the medical weight loss standpoint. And sometimes insurance companies won't even cover that when it comes to weight loss management, which I think is criminal. But then other things like bloating, heartburn, diarrhea, constipation, I think that's one of the positives I'd say about obesity is that it affects every organ system. So I'd say most of my patients who struggle with their weight have issues from a GI standpoint. So then we can talk about their bloating, but really focus on their weight.
That's awesome. Yeah, no doubt about it. All right, here we go. Rapid fire. We're going to get a little crazy for a second. Michelle, we'll start with you. What is the deal with corn in the poop? How does that happen? Why can I chew corn? I chew the hell out of corn. Not anymore. But when I used to have corn and I chewed corn and it seemed like it was properly chewed. And then I look down and there's whole corn kernels in my poop. How the hell does that happen?
So dietary fiber is really not digested by the body. So a lot of people say, oh, I'm not digesting appropriately. I just had, a huge bowl of quinoa and kale and spinach and chia and flax seeds and hemp hearts and chickpeas. They add a million things. Our body, when we were cavemen, we did not have this huge freaking salad that had 30 ingredients on top. That's very rich in fiber. So although dietary fiber is so incredibly important for the microbiome, there is still sometimes too much fiber, only so much our body can handle. And these plant fibers, our body doesn't have the enzymes to break it down. So if people are eating fast, not chewing very well, and swallowing that food bolus, fiber increases transit, so it's going to go through the gut faster than other things. And then you're going to have undigested particles because our body can't break all of it down. So sometimes it's just excess fiber in one sitting, and there's only so much your body can do. So it's actually not necessarily abnormal. It's not necessarily a pathologic state for you to see fiber screws and grains in your stool. You would want to be concerned if you were having a lot of diarrhea, if you were seeing a lot of oil droplets in the stool, unintentional weight loss, things like that, that would suggest more of a malabsorption problem.
All right. Okay, that makes sense. You just scientifically explained a phenomenon that I've always wondered about. Amy, what is it with guys and their man parts? Like they're either itching, they're adjusting, they're sitting on their couch, their hands are around it, they're down the pants. Like, is there a magnet there? Like, what is going on? Why, as men, can we just not leave it alone?
Oh, gosh, I don't know that I was taught that in medical school. I'm not really sure. It can get moist down. It can get moist down in that area, so people can get yeast infections. Women are not the only people that can get genital yeast infections, so that area tends to get a little bit moist if it's hot out especially. But I'm sorry, I can't answer that question. Maybe you can answer that question. Why are your hands in your pants, man?
No, I'm looking to you. You guys are the experts. Come on. How do you not know that? That needs to be on some sort of medical board exam. Amy, as excited as you seem to get about the man parts, is there a day when you just say to yourself, not another 30 penises? By the way, actually, before you answer that, I was listening to a very popular national podcast that has millions of downloads, and they were arguing about whether it's penises or peni for the plural of penis. So could you set me straight on that first, and then we'll get to whether you're ever tired of looking at them?
I sometimes use both words, but would say penises.
That's proper?
Yeah.
Okay. Yeah, I don't know. Actually, the same thing with esophagus. Is it esophaguses or esophagus?
Yeah, no, what is it?
I don't know.
All right. I don't want to be called.
To be honest with you, though, it's so rare that I refer to more than one penis at a time.
Just if I'm going to see Amy, I don't want to be known as an esophagi. I'm just saying. So, Amy, there's got to be like a random Thursday in the middle of like December or like February where you're just like, all right, like I got 20 patients coming to see me in clinic. Like, really, just penises all day?
But she does so much more than just the penis.
Yeah. I would say, like my sister, I guess the penis got me into the field, but is it what keeps me in the field? A penis is one part of the puzzle. When we think about the genitourinary system, it starts up here in the brain, up here in the head, and goes all the way down through the penis. But so much of it is way more than the penis. So many people think urology, penis. That's why, my parents' friends, again, they're like, your daughter's a urologist. I don't understand how you're so proud and you post stuff about what she does. It's one piece of the puzzle. Where I really enjoy these encounters, like my sister, is sitting down with dudes and being like, hey man, let's talk about your body. I got this demo here. This is a cross section of what your pelvis looks like. We're going to start with the bladder and go down from there, and just really educating them on their man parts. And the penis is just part of it. So no, I would never say that I ever go into clinic being like, oh my God, another penis today. What is challenging is that men are complicated. People are complicated. And there are a lot of quality of life concerns that affect men. So my challenge is when I see a guy who comes in with 5 different concerns related to his genital and urinary parts, and my challenge is figuring out what are we going to address today? How do I end up addressing everything without overwhelming my patient and overwhelming me at the same time? But it's hard to do that because everything is related and connected. So that would be the challenge.
All right.
But I think what's interesting really quick with Amy and I is patients will come in blaming their penis, but it may have nothing to do with their penis. It may or testicular pain. It may actually be a hip or a back issue. Mm-hmm. Same thing for me is people will come in and say, I have, particularly in Miami, gastritis, right? They say, lots of, inflamación and mi estómago, but it may have nothing to do with actual inflammation or gastritis. It may have to do with the fact that they have 2 minutes to inhale their food. So they're not chewing their food. They're swallowing tons of air. They're sucking it down with carbonated beverages. And then they're doing 5 things at once. So it's really their body telling them, girl or guy, dude, you need to slow down and chew your food. Yeah. So many times people come in and say, doc, what is wrong with my body? And from a nutrition standpoint, I kind of turn around and say, at the end of the day, we've done the workup. It looks like there's nothing, significantly wrong with your body. It's your body telling you there's something wrong with your food, or there's something wrong with how you eat. And it's our body telling us there's something wrong with what we're doing.
right, so
yeah, you call my sister and I like Dr. Pearlman, but I think in so many ways we're Detective Pearlman and Pearlman.
yeah, no, that's true. That's why I love you guys, because you do attack it from that angle, and that's really important. Um I've always been really impressed by doctors that do kind of play that detective role. Because I think that's important to get to the bottom of solutions. Speaking of solutions, so for me, it's been a couple of years that I felt sluggish, and I would be that guy that would come home and want to just, as we would say, need a schluff on the couch, and wasn't that active. And to me, it was always okay. I'm obese, like that's my body, and I need to exercise, and I'm not, and all of that stuff. And then I finally forced myself to go test my testosterone, and it was low. It was really, really low. Now, obviously, we doing the research, obesity can obviously have a big impact in low testosterone, as can other health conditions. And so I found myself, I went to my regular doctor. He sent me to an endocrinologist who agreed that I should get testosterone shots. And I just started last week, so I don't think it's right that it should have an impact yet. But in a random weird thing, I didn't realize that testosterone was given in the buttocks. And I was asked by the nurse who was giving me the shot which butt cheek I wanted the shot in. And then I asked her, I didn't realize there was a non-dominant butt cheek for me to select. Like when you get shots and you're like,
Well, but it depends.
I always pick the left arm because I'm right-handed. It's like, do I pick my left cheek because I'm right-cheeked? I don't understand the question.
But you're going to be the one injecting yourself, right? So at the end of the day,
no.
You're not.
Let me don't play that. I'm
No.
going to the doctor. Like, no,
Oh,
we're
okay.
not. I'm not. Listen. I'm not doing that. So I'm going to the doctor. But I felt it odd that she asked me which cheek I wanted in. Like, I don't know. You pick. Which looks better? I don't know, really. But I just want to use myself as an example of saying and say, listen, low T is a thing. It's not just something that's talked about as on the radio or on TV. It is a thing. It affects people, and both of you see patients that are impacted by this, whether it's with weight loss or with sexual health issues.
But just to touch on, the obesity and low T thing, there's so much overlap there. So when I started out in practice, a lot of us will say, well, sir, if you lose weight, your testosterone level will get better. So why don't you go to the gym and build some muscle mass and eat healthier, and we'll check your T level in 3 months, and I'm sure it's going to go up. But it's really hard to do that when you go to the gym and you're not seeing weight loss and you're not seeing muscle mass gain. It's you lose your motivation. So I think the best results come from when you attack everything at once. You talk about the nutrition, you talk about the exercise, you treat the low testosterone, and you do everything at once, and you see what happens. But the research now shows that for men coming in with low testosterone, when you put them on therapy, it can improve all these metabolic syndrome parameters: waist circumference, lean body mass, diabetic control. All of these really important things treating testosterone can help.
Michelle, I'm sure, with your weight loss, clinics and seeing men, that's obviously, if they have low T, that can play a big part in that weight loss journey.
Yes, that's actually part of my screening questions. Is I ask people, and usually it's kind of towards the beginning of the interview, and they probably look at me and say, I came for weight loss. Why are they talking about my sex drive? But that's actually, I'd reached out to one of the urologists at Miami, and I said, what sort of questions should I be asking people to figure out whether or not I should send them to urologists? Because I'm not going to start giving someone testosterone injections. That's just not in my wheelhouse. But some of the questions I asked that Amy touched upon are, do you have low sex drive? Are you having erectile dysfunction? Are you urinating at night? And do you get really tired during the day? And those are my 4 kind of basic screening questions that I ask all my patients, my male patients coming in for weight loss.
All right, you guys, it's been so incredibly fun. But before we let you go, I want to give you a chance. Where can people find you on the cyber web social medias? Where would you like people to go? Michelle, we'll start with you since Amy's muted.
So my Facebook is Pearls of Wisdom MD, and my Instagram is Michelle Pearlman MD. I keep it pretty simple. I post a lot of my nutrition stuff on there, my recipes, food blogs, and Amy and I are working on a website currently, and we'll be posting a ton of information on that site in the next coming months.
Amy, I know you're on Twitter because I just followed you before. And where else can people find you, or where can people find you, Amy?
Yeah, I'm on Twitter. I'm on Instagram, Amy Pearlman MD. And, the purpose of this website that my sister and I are creating are just, you don't have to see one of us in the office to live a better life. Our goal is to find the reliable resources, the reliable content, and to give that to people in a way that inspires them and encourages them to make changes. And so that's what we're hoping to do with this website, is provide that reliable information. But also, one of the reasons why my sister is so successful with having a lot of her patients lose weight is she's right there with them in the process. My sister and I are just like everyone else. We struggle with very similar things. And so we want people to know that, hey, we are just like you, and we're going to go through this together.
That's awesome. You guys are the best. I am so happy that I've gotten to know you and able to share your stories with my audience. And I really appreciate you taking the time. Amy, if you'll text me that vacuum pump, that would be great. I might need 3 or 4. That's a whole different story. We'll take that private. Dr. Pearlman, thank you so much. Have a great night, and hopefully we can do this again sometime.
Awesome. Thank you.
Thanks, Brian the Beast. Have a good night.
Will do.